So, good day and welcome to this webinar on FRAXplus refining risk prediction. My name is Dominique Pierrot. I'm the science manager at IOF and I'm delighted to moderate this webinar. Before introducing the speaker of the day, I would like to inform you that attendees are automatically muted. And I would like to encourage you to ask questions during the webinar by typing them in the Q&A box. I will voice them to the speakers towards the end of the webinar. This being said, now I have the great pleasure to welcome Professor Eugene McCloskey, who is Professor of Adult Bone Diseases at the Mellon B Center for Musculoskeletal Research at the University of Sheffield, and Director of the Medical Research Council versus Arthritis Center for Integrated Research into Musculoskeletal Aging. He is past president of the Bone Research Society, past chair of the Royal Osteoporosis Society Research Academy Effectiveness Working Group, board member of the IOF, and past member of the ECTS Clinical Practice Action Group. As a member of the National Osteoporosis Guide Group in the UK, he has helped integrate fracture risk assessment with clinical management. He has published over 500 original articles in research areas encompassing treatment of cancer-associated osteolysis, osteoporosis and Paget disease, vertebral fracture definition, non-invasive skeletal assessment, and the development of FRAX. His commitment to clinical and research developments in the field has been recognized by the 2016 IOF Medal of Achievement and the 2018 ECTS Philippe Bordier Clinical Award. Thanks again, Professor McCloskey, for having accepted our invitation to present today, and we are now listening to your presentation.
Thank you very much, Dominique, for that rather detailed introduction. And it's a pleasure to take part in the webinar today. And over the next 35 or 40 minutes, I'm just going to present two parts of the talk. The first part is a PowerPoint presentation looking at the reasons why we need something like FRAXplus currently. And then in the second part, I'm going to show you a little video of just some of the adjustments that are available within FRAXplus and how it works. So these are my disclosures. So FRAX has been with us now for 15 years. It was launched in 2008. It was launched really following a call by the World Health Organization for tools that could be used in tackling non-communicable diseases across the world. And osteoporosis was recognized as one of the diseases that was going to cause a global burden of morbidity and increased mortality as a consequence of the fractures that arose in osteoporosis. And they wanted to develop a tool that could be useful in healthcare settings that might range from expensive systems to well-funded systems in some countries to other settings where the medical care was being provided in rural communities and access to equipment and other expensive tests might not be so readily available. So that was really the driver to develop a tool such as FRAX. And the tool was really designed to integrate information about risk factors for fracture so that those working in primary care and communities who didn't have perhaps the expertise in dealing with the everyday care of osteoporosis could assess the risk of fracture in the individual sitting in front of them. And then that would allow them to make some choices about the use of medications and things that could reduce fracture risk. So there was a need for it in care of patients with osteoporosis. There was also a need to supplement the information that was provided by bone mineral density. And of course, bone mineral density has a very strong relationship with fracture risk. And this is shown here on this slide. Many of you will have seen this slide before. This is looking at the T-score along the x-axis And then the incidence of fractures, or the rate of fractures, in the orange bars, and the number of women with fractures in the darker or purple bars. And you can see as the forearm, this is the forearm T-score. The forearm T-score decreases as we go to the right of the slide, and the fracture rates increase in a fairly dramatic stepwise fashion. One of the problems is that those at the very right-hand side of this graph have a very high risk of fracture, but there are actually relatively few of them within the population, so that they contribute relatively small numbers of fractures to the overall fracture burden within the population. Indeed, most of the fractures occur in patients who are not really classically osteoporotic as defined by bone mineral density. So this again just raised the need for other factors that could be added to bone mineral density that would help us to identify those at highest risk of fracture. So we set about doing a number of meta-analyses of risk factors that we knew had a relationship with fracture risk, but we needed to know how those risk factors could be integrated together in a tool such as FRAX. And one of the tools I've just mentioned is bone mineral density, or one of the risk factors is bone mineral density. And many of you will carry around numbers like 2.8. And 2.8 was the increase in risk of hip fracture for a 1 standard deviation decrease in femoral neck BMD. But that 2.8, that single number, doesn't really explain the whole story of the relationship between bone mineral density and fracture risk. And on this slide, you can see that the green line represents the 2.8 average gradient of risk. But at younger ages, the gradient of risk per standard deviation decrease in femoral neck BMD is much higher than 2.8. And at older ages, at the age of 80 and 85, it's lower than 2.8. So if we know this relationship in more detail, we're then able to add age and femoral neck BMD into a risk calculation that is more personalized to the individual that we're looking at in the clinic. So that BMD meta-analysis was complemented by a number of other meta-analyses, again, looking at fairly well-established, but also simple risk factors that could be captured easily in primary care settings. And a number of meta-analyses were published that looked at the relationship, for example, between prior fracture and subsequent fracture risk. In this slide, we're looking at hip fracture risk, family history of hip fracture, current smoking, glucocorticoid ever use, alcohol intake of 3 or more units per day, or on the right of the slide, rheumatoid arthritis. And you can see in the grey bars that each of these risk factors, in the existence of each of these risk factors, was associated with an increased risk of future hip fracture in the individual. And in the orange bars, we've included bone mineral density in the analysis, and you can see that this slightly reduces the relationship between the risk factor and future fracture, but all these risk factors remain independent fracture risk in the presence of bone mineral density. So we can add these to bone mineral density, age, gender, and combine these risk factors into a simple single tool to predict fracture risk. And that gave rise to the FRAX tool. As I say, that was launched now 15 years ago. And it's a very simple questionnaire. The questionnaire you can see on the slide here. It's available in a number of forms. It's available on the website form where you can individually do calculations using the FRAX tool, but it's also embedded in bone densitometers around the globe. So many patients are having fracture risk assessments that we really can't measure or count at this point in time. The fracture risk engine is constant across the whole system, but what we have to do then is to calibrate the output from FRAX to the epidemiology of fracture and age-specific mortality in the countries where we want to use it. And that's really because if we take, for example, a 65-year-old woman with a BMI of 24 or 25 who's had a prior fracture, then that woman globally doesn't have the same fracture risk. So her risk of fracture will be low in some settings and it will be high in other settings, so that we have to calibrate her risk to the country or the ethnicity within which she lives. And that's given a rise to over 80 models now, 80 countries or territories that have FRAX models over the last 15 years. And this is a snapshot from earlier this year, just looking at the number of calculations that have been done through the website. As I mentioned before, this doesn't capture those that are done through the bone densitometers and other mechanisms, but we've well over 40 million calculations, and we're still doing about 3 million plus calculations through the website every year. One of the things that we realized fairly early on was that we had to integrate the output from FRAX with clinical guidelines. And one of the first countries, perhaps not surprisingly, since FRAX was developed in the UK, was the establishment of a national osteoporosis guideline group in the UK that would allow linkage of the output from FRAX to national guidelines. And so you can see on the left-hand side of the graph here that in the UK model, once you've done the calculation and you get the two numbers, the major osteoporotic fracture probability and the hip fracture probability, then you also have a button that appears which says View NOG Guidance, and that clicking on that button will take those risk probabilities through to the National Osteoporosis Guideline website, where we have a sort of traffic light system of graphs, intervention thresholds, assessment thresholds, and that allows the GP or healthcare professional in the primary or secondary care settings to inform them, to help them to make decisions about whether this patient needs further assessments, for example, needs to be referred for a bone density measurement, or whether they should have treatment. And the National Osteoporosis Guideline Group has just last year updated their guidelines. So that's really a bit of background, but we've always known that there are limitations of FRAX. And shortly after the launch of FRAX, for example, IOF and ISCD got together to publish a number of documents about the limitations of FRAX. And some of those limitations are well known to you. So, for example, glucocorticoid use is ever use. We don't have anything in there about the dose of glucocorticoids or the duration of glucocorticoids. Smoking, we've got nothing. We've got current smoking, not past smoking, ever smoking, or we have no information about the number of cigarettes per day, for example. Prior fracture is a very strong risk factor within FRAX. But it's prior fracture, yes or no. And of course, some patients with prior fracture will have had one fracture, but some will have had several fractures. Some will have had fractures in different sites, and those sites impact on future fracture risk, and so on. There are other variables that aren't included directly in FRAX, and probably the most common one that gets commented upon is falls. And falls, we know, are a risk factor for future fracture. So we know that FRAX can predict falls because that's not surprising. Age is in FRAX and older age is associated with falls. Prior fracture is in FRAX and most fractures occur as the result of a fall. So it's not surprising that we capture some element of falls associated risk within FRAX, but we recognize that having falls as a separate input would still enhance that prediction further. And then finally, more recently, over the last few years, there's been a lot of talk about the time dependency between certain risk factors and future fracture risk. And the recency of fracture has got a lot of attention, and I'll say a little bit more about that as we go through. I should just mention at this point that there are limitations to FRAX, of course, but there's limitations to really all of the techniques that we use in the clinical setting. For many, many years, we have managed osteoporosis with a really large focus on the BMD and the T-score. but the T-score itself doesn't accommodate all the other risk factors that might be present in an individual. We as physicians and nurses know more about the patient in front of us than the T-score does. We know more about their age, their fracture history, their falls history, their glucocorticoid use, and so on. So if we just base everything on the T-score, we're limiting our ability to target treatment effectively to those at most risk, and so on. So there's a number of deficiencies or limitations in all the tools that we use, and we should recognize those and try to address them as best as possible. So that brings us on to FRAXplus, and FRAXplus was really designed, at least in a transitional way, to address some of these limitations of FRAX. And this is just a screenshot from the FRAXplus website, and it shows you that at the moment we've got adjustments for recent fractures, we've got adjustment for the dose of oral glucocorticoids, we've got adjustments for TBS, for the duration of diabetes, for recent falls, that's falls within the previous year. We've got adjustments for discordance between the T-scores at the femoral neck and the lumbar spine, and in some centres where there's also attention paid to hip axis length, there's an adjustment that can be applied for that. So there are several adjustments that are available at present. Really, given the limitations of the data that we have available to us, we really only allow one adjustment per patient. That's the way the model works at the moment. And if a patient has several of these risk factors, then the advice is to adjust for the strongest of these modifications rather than the weakest of the modifications. The FRAXplus has some other advantages, and one of those advantages is that you can sign up and set up your own account. And in so doing, you create a spreadsheet or a database of the various calculations that you as a user do, so that you can compare someone's current FRAX score with a FRAX score that you have done or will have done in the past. You can export those results. You can use them to analyze the characteristics of the patients going through your clinic, and so on. So that's available as well as part of FRAXplus. What any of you that have been using it will know that there is a charge for actually doing the adjustments or modifications, and that's something that just really has arisen because of the place and time that we find ourselves in terms of regulatory requirements for software as a medical device. And FRAX, like many pieces of medical software, are now undergoing regulatory requirements in various jurisdictions, and that has a cost to it that sadly needs to be covered. We continue to look at other funding models. FRAX itself will continue to be free at the point of use. So for the last few slides, I just really want to talk about some of these adjustments, and one that has got a lot of attention recently is the recency of fractures. And these two graphs are from the same study, from the Reykjavik study. And the recency of fracture has been long recognized. There are several studies going back many years that show that fractures cluster together in time. And this is on the left, just looking at those patients who, within the Reykjavik study, had a fracture, either at the hip, the forearm, the spine, or the humerus. And then we followed them up to 10 years after that fracture. And this graph looks at all of those who, during that 10 years, had a further fracture. So it's not all the patients who had hip fracture or who had forearm fracture. It's just those who went on to sustain a refracture during those 10 years. But of those that refracture, you can see that a significant proportion, 50% to 60%, depending on the site of the initial fracture, occur within the first 2 to 3 years after that initial fracture. And on the right-hand side, we've expressed it as hazard ratios. And you can see that the hazard ratio for spine fracture, for humerus fracture, and for hip fracture are particularly high within the first couple of years after the hip fracture, and then decrease. They never get back to a hazard ratio of 1, which would be the hazard ratio within the general population or the whole population. But it remains increased over time. but it's particularly high within that first couple of years. So it's we know that the recent fracture increases the risk of fracture, and we can translate that into an impact on FRAX probabilities. And we've done a number of analyses for different risk factors, looking how we can modify the FRAX probabilities. What that entails is the development of multipliers that can be applied to the FRAX probability to adjust it for the increased detail about the risk factor. So in this analysis, we're looking at recent fracture, and the FRAX probability has been calculated with the prior fracture box ticked to yes, because they've had a fracture. And then these multipliers are applied to that output. And it would have been nice if it had just been one number, but it's more complicated than that. So for example, there's a marked age dependency. So this is just looking in women. And you can see, oops, if we go back, you can see that in the case of a recent vertebral fracture, then at the age of 50, the multiplier that needs to be applied to FRAX probability is in the region of 2.6, whereas at the age of 90, it's more like 1. And you can see that the multipliers are different. They're quite high for recent vertebral fracture and hip fracture, and they're quite low for recent forearm fracture. So it's site dependent, it's age dependent, it's gender dependent, because the multipliers are slightly different for men, and that makes it a bit more complicated to apply. So the easiest way to do that is to build it into software such as FRAXplus. So we've launched the FRAXplus website. Within that, there is still the free-to-use FRAX tool. The look of the tool is slightly different, but the construct is identical. The calculation is identical. So in this individual who's had a previous fracture and is a smoker, when the results come up, you get a new green bar that says, do you want to adjust your results through FRAXplus? And that's something that I will demonstrate in the video that follows. I just want to finish this part of the presentation by just explaining that FRAX itself is in transition, and many of the adjustments that we now have within FRAXplus, we hope will become permanent features embedded within the next iteration of FRAX. Some of you may have seen recent publications arising from the new collection of cohorts that are allowing us to undertake many meta-analyses. These meta-analyses are going to address the existing risk factors to see if the coefficients have changed, and they'll also look at new, more detailed risk factors that might be added into the next iteration of FRAX. Really, there has been an explosion in the number of prospective epidemiological studies in fracture risk globally. So this is just a comparison of the data set that was used to build FRAX between sort of 2000 and 2008. And you can see that in total, we had about 46,000 individuals in the database that helped us to build FRAX. Now, in the 64 cohorts that we have available to us, we've actually almost got as many incident hip fractures alone as we had the number of individuals taking part in the data set that allowed us to build the original FRAX. So the power to detect and reaffirm relationships between risk factors and explore the interplay between risk factors is much greater than it was, and that's a work in progress that we will continue to publish these meta-analyses over the next 2 to 3 years, and at some point then launch an updated FRAX model. So for this part of the presentation, I just want to summarize that as we know, FRAX is a well-established clinical tool. It's used in many guidelines worldwide to guide assessment decisions and treatment decisions. Of course, patients, and we recognize those. FRAXplus is an approach in a transitional setting to address some of those limitations. That allows us to modify some of the existing risk factors by taking into account the recency of fracture in the presence of a prior fracture, and also to add in factors that we haven't already got in FRAX, such as falls, for example. And as I say, we will continue to work towards updating FRAX and launching a new model of FRAX in the next few years. So I will stop there, and I think Dominique might say a few words just while I take care of the technical issues and get the video started.
Yeah,
so,
exactly. Just, yeah, so that you can upload the video. So thanks very much. So that was the first part of the webinar. And now Professor McCloskey is going to show a short video where he will demonstrate the possible adjustments, the possible adjustments on the FRAXplus website with the correlation with the guidelines. So you can really understand how this adjustment can be used.
Okay, so I'll start the video.
But it's black. Okay, perfect.
Hello, my name is Eugene McCloskey from the University of Sheffield, and over the next 15 to 20 minutes, I just want to demonstrate some of the adjustments that we are now providing through FRAXplus, an add-on to the FRAX tool that allows us to look at some of our existing risk factors in a bit more detail, but also to take into account adjustments of fracture risk by variables that are not yet included within FRAX, but are clinically recognized as important risk factors. So this is the homepage of the new platform for FRAX and FRAXplus. I've already logged into my account, so I'm going to go now and do an online calculation. For the purposes of these illustrations, I'm going to use the UK website for no other reason than that the results that we have output from FRAX and FRAXplus can be then taken through to the National Osteoporosis Guideline page in the UK. And that's just really to illustrate the potential impact of some of these adjustments on decision making and decisions about interventions and or more investigations and so on. It's not to recommend the National Osteoporosis Guideline Group's thresholds for worldwide usage. So here I am in the UK FRAX tool. I've entered an identifier for the patient that I'm assessing. This is a 72-year-old woman. You can see that her weight is 63 kilos. Her height is 167 centimeters. And I've only given her one risk factor here, that is rheumatoid arthritis. As yet, she hasn't had a bone mineral density assessment done. And if we press the calculate button, we'll see that this lady has a major osteoporotic fracture probability of 18% and a hip fracture probability of 6.8%. And many of you will recognize that some of those values are above some of the thresholds that are used around the globe, and this lady might be considered suitable for immediate intervention in some healthcare settings. But in the UK, we would follow this through by taking her through to the NOG guideline by clicking on the red button here. And if we do that, that takes the major osteoporotic fracture probability of 18% through to the NOG guidance page. And the primary care specialist sees a traffic light graph like this. You can see this lady's value, the X, lies within the amber area. That amber area is recommending that the doctor refers this patient for a bone mineral density measurement. You can see that she lies not only within the amber area, but she lies below this thin black line, which is actually the intervention threshold within that amber area. So we could refer her for bone mineral density, but she might be frail from her rheumatoid arthritis. There might not be easy access to bone mineral density assessments. So are there other risk factors that we might be able to take into account about this lady? And one of those risk factors we can illustrate now, because we might know that this lady has, for example, an increased risk of falling. So we can then take her through to FRAXplus, because that adjustment for recent falls is available to us through the FRAXplus website. So I've clicked through on the FRAX adjustments. You can see that it's summarized the input variables for this lady and brought through her 10-year major osteoporotic fracture probability and her hip fracture probability. If I scroll down further, these are the adjustments that are available and not available to me. In the orange bars, these adjustments aren't available because this lady hasn't had a fracture. She's not on oral glucocorticoids. She hasn't had a bone density scan done, so there's no access to TBS values, for example. There's no access to discordance between lumbar spine and femoral neck T-scores, and there's no access to measurements of hip axis length. The adjustments that are available to me is that if she had diabetes, I could adjust according to the duration of diabetes. But what I'm going to do is to adjust for her other known risk factor, which is recent falls. And if I then click on the green bar here, it brings up a simple questionnaire. How many falls has she had over the previous year? And I'm going to make a worst case scenario here that she's a multiple faller with 3 or more falls. And we click on adjust the probability. And you can see that the report now shows the original probabilities for major osteoporotic fracture and hip fracture, but we've adjusted it for the number of falls in the previous year, and that's 3 in this instance. And you can see that her major osteoporotic fracture probability has increased from 18% to 28%, her hip fracture from 6.8% to 12%. So if we then take that through to the NOG guidance, you'll quite clearly see that this lady now falls within the treatment category. She is well above the intervention threshold. So in the absence of access to BMD, combining the information about falls with her history of rheumatoid arthritis and age and BMI would allow us to make a treatment decision in this lady. And of course, that treatment would not just be a bone targeted treatment, but would also be approaches to address and reduce her falls risk. So if we go back then to the original calculation, and we can do that by clicking on a new calculation here. It's recorded the previously entered information. And now I could have looked at the result lying in the amber area and sent her through for a bone mineral density assessment. So I'm just going to put in her T-score. Of course, it's the N Haynes femoral neck T-score. And I'm going to give her a T-score of -2.3. So she's not quite within the osteoporotic range at the femoral neck. And again, if we calculate that, that gives her a 10-year major osteoporotic fracture probability of 16% and a hip fracture probability of 4.8%. And again, recognizing that some of those values would lie above intervention thresholds in some healthcare settings. But again, if we take this through to the NOG guidance, you can see that the bone mineral density at -2.3 is not far from average for her age at the age of 72. And these values lie within the green area. But what we can do then is to think about other adjustments, other information that we might take into account. And if we do that and go back to the website and click on the FRAXplus again, now we see that a number of other adjustments are available to us because of bone density measurements being carried out. And just to illustrate the impact, I'm just going to adjust this lady's values for a TBS value. Her TBS value was quite low, so we're putting in a value of 1.05 here. We need to tell the calculator what scanner the TBS was measured on. So in this particular case, it's a logic scanner. We adjust the probability. And again, we see the original outputs from her with a T-score of -2.3, but adding in the additional value of the TBS and the manufacturer, this increases from 16% to 21% for major osteoporotic fracture, and from 4.8 to 6.4% for hip fracture. And if again, we go back and plot that on the NOG guidance, you can see that the knowledge of her TBS has increased both her major osteoporotic fracture probabilities and her hip fracture probabilities to above the intervention threshold in the NOG guidance. So if we go back again and we use the same scenario, of course, here she is with her T-score of -2.3 now that we've measured bone mineral density. But we could assume that she's on long-term treatment with glucocorticoids. And if we feed that into the calculation, then we'll see that she has a 10-year probability now of 24% for major osteoporotic fractures and an 8.4% for hip fractures. And again, if we take that through to the NOG guidance, you can see that this study is very clearly a case of treat. In the NOG guidance, we have two areas under the treatment curves, if you like. One is treatment with oral bisphosphonates or other agents which are perhaps less potent in terms of fracture risk reduction. But in patients at very high risk, then they might be considered for certainly more potent antiresorptives such as subcutaneous denosumab or intravenous zoledronate, or even in some cases upfront or first line use of bone forming treatments such as teriparatide and romosozumab. So again, this lady is on glucocorticoids. And if we go back to her calculation, we can consider that input from the glucocorticoids. We go down now, we're able to adjust for the dose of oral glucocorticoids. And if she's on a 7.5 milligrams or more daily dose in the long term, we can click on yes on that. Adjust her probability. And again, you can see that her probabilities increase from 24% to 28% for major osteoporotic fracture probability, and from 8.4% to 10% for hip fracture. And again, on the left, you'll see that the reason behind the adjustment is recorded for clarity. So again, if you take that through to the NOG website, you can see now that this lady is well within the treatment category in the major osteoporotic fracture probability and well into the consideration of specialist referral and consideration of more potent therapies that I've mentioned before. So the knowledge of the glucocorticoid dose might influence the decision making. So the final thing that I'm just going to illustrate for you today, if we go back and we go back to our original lady, we're still going to have our T-score measured at -2.3. We're going to take out the glucocorticoid exposure, but she has had a previous fracture. And again, if we redo the calculation, you can see that now with these two risk factors of previous fracture and rheumatoid arthritis, bone mineral density of -2.3, her major osteoporotic fracture probability is 24%. Her hip fracture probability is 7.1%. And again, if we clicked on the NOG guidance, that will take us through to here. And you can see that again, this patient falls very clearly within the treatment area, but falling into the area where we might be suggesting more traditional oral antiresorptives or other therapies rather than the more potent agents. But she has had a prior fracture. So we can now take that through to the website. You can see that the glucocorticoids is no longer available to us because I made that a no response. But the recent fracture adjustment is available to us. And if I click on that, then we can enter information about the site of the previous fracture. And this is the previous fracture within the last 2 years. So just for this example, I'm just going to click a vertebral fracture. And it occurred, we think, there's a history of a fall and back pain 6 to 12 months ago. And we're going to click on that. And then again, adjust the probability. And this time you can see that her major osteoporotic fracture probability has increased quite dramatically from 24% to 39%, and her hip fracture probability has increased from 7.1% to 11%. And again, if you take that through to the NOG guidance, then you can see that this lady has the black cross here as well towards the upper end of the graph, and she has a very clear treatment options that will be discussed to largely include very potent antiresorptives or even first-line bone forming treatments. So this is just an example that I've used in this case of this 72-year-old lady with underlying rheumatoid arthritis throughout the assessments. In FRAXplus at the moment, we can only undertake or recommend that you only undertake just one adjustment. And you can see that some of those adjustments are more potent at uplifting the fracture probabilities than others. And this is just an illustration of the potential impact of these FRAXplus modifications and adjustments of FRAX outputs that will inform our clinical decision making in the future. So thank you for listening, and I'll be happy to take any questions. Thank you.
Thank you very much, Professor McCloskey, for this brilliant presentation. I'm sure that it was greatly appreciated by our audience. And now I would like to move on to questions. Can you show the slide for the Q&A just for the recording? Exactly. So, perfect. So just maybe the first question by Dr. Al-Makbali. She's asking if it's possible to install a FRAX algorithm in the hospital IT system rather than to use it on the website, from the website.
Yes, it is possible, and it's probably one of the most commonly asked questions that we're getting these days. We're certainly involved in active conversations with various healthcare providers in many countries around the world about embedding the calculation into electronic patient record systems. That's something that we are very keen to get involved with. And if any of the people who are listening today want to go down that line, then by all means, please drop me an email, and we can engage in a conversation to try and work towards that.
Thank you. Another question by Dr. Ong. If the FRAX result already exceeds the intervention threshold, does FRAXplus add any other clinical value?
Again, up until fairly recently, if it was over the intervention threshold, many clinical guidelines would just say treat, but yet they didn't have the ability to say treat with what. Because until the last 5 years, we didn't have head-to-head trials where we could say that one drug was better than another drug at reducing fracture risk. But now we've had, for example, the Vero trial with teriparatide versus risedronate. We've had the ARCH trial of romosozumab versus alendronate, both trials showing that the bone-forming agent was superior to the anti-resorptive in both the degree of fracture risk reduction and obviously the rapidity with which that anti-fracture effect was seen. So now that's really given rise to this concept of being above the intervention threshold. But if you're just above it by maybe a small amount, if you want to put it that way, then it would be treat with more traditional established treatments. But if you're further above it into the very high risk thresholds, above the very high risk thresholds, then you might be considering first-line bone-forming treatments, or at least certainly more potent parenteral anti-resorptive therapies. So I think the ability to modify the risk assessment using some of the FRAXplus tools will aid us in deciding the choice of treatment. It's not just choice to treat, but a choice of which treatment we should actually use. And I think that has added value.
Thank you. There is another question about FRAXplus. So FRAXplus takes into account previous falls within the last 12 months. Why aren't multiple falls over the last 5 to 10 years taken into account?
Partly because we just don't have the data. We just don't have that level of data from within the cohorts that we're using to build FRAX. We did try to put falls into the original form of FRAX, but it's a relatively small number of cohorts. Not all of them asked about previous falls. And at that time, the question that was asked about previous falls was quite varied. The nice thing is that in the 64 cohorts that we now have, we have a substantial number of cohorts that have asked about falls, and they've asked about falls in the previous year. have you had a fall in the previous year? If yes, how many falls have you had in the previous year? So that really gives us a nice database to build a well-structured, validated adjustment to FRAX. We would love to be able to take account of falls over the longer term, but we're unable to do that. The other thing to say is, however, that there is a time dependency of the falls as well. So prior falls, the effect of those prior falls wanes over time in terms of their impact on fracture probabilities. So again, recency of fall is an important factor to take into account.
Thank you. One question from Dr. Joss. Can you do several adjustments with FRAXplus, but using them one after another in sequence?
Theoretically, you could, but it's complicated because you would have to generate someone in FRAX who has the probabilities that are generated by the first FRAXplus adjustment, because we don't allow, within FRAXplus itself, we don't allow that sequential adjustment. And that's for a number of reasons, but I think it's important to realize that these adjustments are useful. They're illustrative of the impact of the taking that additional piece of information into account. But of course, there's errors within the adjustments because they frequently come from one or a small number of cohorts. And if we do multiple adjustments, then we're multiplying error by error. And that can sometimes give results that are possibly somewhat unreliable. So at the moment, we're taking a very conservative approach where you should adjust, or you can adjust for one of these variables. And the important thing is to adjust for the strongest one that's present rather than the weakest one.
Thank you. Dr. Al-Makbali is asking, is FRAX is applicable to patients with secondary causes of osteoporosis, for example, hypogonadism, thalassemia?
So as many will be aware, within FRAX we have a secondary osteoporosis button, and that was built into the tool to take account of a number of conditions that were associated with an increased risk of osteoporosis. Back in the early 2000s, when we were building FRAX, we took a very conservative approach that the causes of secondary osteoporosis were assumed to impact on fracture risk by their effects on bone mineral density. And whereas that might be true, for example, hypogonadism has a big impact on bone mineral density, you might assume that once you know their bone mineral density, you've taken account of their hypogonadism. That was a very conservative approach, partly informed by the lack of data that we had at the time. But of course, now we know that hypogonadism doesn't just affect your bone mineral density, it affects your muscle strength. So as we go forward with FRAX2, that secondary osteoporosis basket, if you like, will undergo a lot of examination with lots more updated data. And that will allow us to take into account the disease process itself, if we continue to have a disease-specific increase in fracture risk. Or perhaps we can build in measures such as muscle strength, gait speed, bone mineral density that might take account of that particular disease's interaction with fracture risk, and allow it to take that into account that way. So it's a case of watching this space in terms of the secondary osteoporosis causes.
Thank you. A question from Dr. Agnus Dei. How many years do you think are needed to have all the adjustments available? I suppose it depends how many adjustments you are going to develop.
Yeah, I mean, the FRAXplus adjustments themselves, I think we're regarding as a living tool. So that as data comes through that allows us to make an adjustment, and we can add that to FRAXplus while we're waiting on the next iteration of FRAX coming. I think the next iteration of FRAX, we're looking at 2 to 3 years of meta-analyses before we can really combine that into updated and fairly final version of the next iteration of FRAX.
Thank you. Dr. Wu is asking if there is any possibility to use FRAX or FRAXplus for interventional follow-up.
Again, that's really something that we've discouraged. Certainly for FRAX at the moment. We've some nice data from studies with Bill Leslie, for example, in Manitoba, that as we just naturally age, our FRAX goes up anyway because our age increases. And many of the other risk factors don't go away. We could stop smoking, for example, and that might reduce our FRAX scores. But the only thing that can really impact it is bone mineral density. And of course, if we have drugs that impact on bone mineral density, then that will have some impact on the FRAX score. But that beneficial effect on bone mineral density will be offset by the increased age. And so I don't see a role at the moment for FRAX or FRAXplus really in monitoring the response to treatment. And it's probably easier just to focus the monitoring of these treatments on either bone density, because that's what they're impacting directly, or bone turnover markers, for example.
Thank you. Another question from Dr. El Miedani. How often can we repeat FRAX measurement?
Well, the easy answer is as often as you like, but that's not really the best way to do things. I think it depends on the clinical situation. It's easy to say that if someone develops a new risk factor, be that fracture, be that starting on glucocorticoids, then that's a time to undertake an updated reassessment of FRAX. In a routine healthcare setting, then it's probably reasonable to undertake a FRAX assessment every 3 to 5 years as a sort of guide, but there's no hard and fast rule about that. It's really driven by the change in risk factors in the individual.
Thank you. Dr. Pagana is asking whether you have information about mobile application for FRAXplus.
Yes, so we did have the FRAX tool available for mobile phones, for iPhones and things in the past, but that's something that we haven't supported very much over the last few years. The good news is that the new platform is being written in a updated software version that will be fairly readily adaptable and usable on mobile devices. So we think that will come through in the very near future.
Okay, thank you. Then we have many questions from people from country where there is no FRAX model. You know, what can they use? Okay, so
we recognize that there's still quite a lot of work to do in developing models for different countries. The ideal thing is to collect the data that allows us to build a FRAX model for your country. And the minimum requirement there is the age-specific rates of hip fracture. That's the minimum in men and women, for example, from the age of 40 up to the age of 90. So if you have a data set within the country that can generate that, or you can set up a study that will generate that over a year or two, then that's the ideal. If that data is just impossible or is not going to be available in the short term, then what we can do is to look at the countries around the particular country of interest to see whether the hip fracture rates might be assumed to be similar to the fracture rates within the country that doesn't have the model. And we can adapt the hip fracture rates from a local country, similar ethnicity, for example, and combine that with the mortality rates, because FRAX needs information not just on fracture rates, but mortality rates. But mortality rates are usually available through data sources such as the UN, and we can use that with the hip fracture data from another country to develop a model that, at least in the interim, would work for that particular country. So we call them hybrid models because they're a hybrid between one country and the country of interest that wants to develop the FRAX tool. So again, if anyone's interested, by all means, drop me an email and we can discuss that.
Yeah, some people also are asking, you know, what you do in the low income country, or if countries where there is no FRAX model. So maybe,
Yeah.
if
I mean,
anybody, like people can also write to us. I will give the generic email address at the end of the webinar, and I will be happy to share some specific questions from the audience if they want. If people have more detailed question about their country specificity. So now I think it's time to conclude. I'm sorry if we don't have really time to answer all the questions. I would like to thank you all for your participation in this webinar, and we will post the recording of this webinar on the IWF website, and you will receive the link to the recording by email tomorrow. You will be prompted to fill in a survey immediately after this webinar, and we would appreciate your input and comments. And before closing this webinar, I take the opportunity to remind you that the WCO IOF SKO 2024 Congress is also a unique platform to get the latest scientific updates from our experts in the bone field. So we really encourage you to attend this meeting. And so, like I mentioned before, if you have any questions, comments, please do not hesitate to send them at webinar@osteoporosis.foundation. And I would like to thank you again, Professor McCloskey, for this outstanding talk and for answering all the questions. And goodbye to everyone.
Thank you very much. Goodbye.